So I'm Dr. Wasana, that I'm the nutrition physician at Badul Hospital. Today that actually I'm going to, this is not a kind of a typical lecture because here's not a PGM students know that we are here to just share our own experiences related more practical points related which need when we are managing cancer patients in perspective of nutrition. So actually within next 15 to 20 minutes, I would like to go through these objectives. By the way, that why this nutrition is really important when we are managing cancer patients. Because that there's even diabetes, no? That diabetes also, there's a huge role in nutritional management. By the way, when it comes to the cancer, what happened? That not only the disease itself, even the treatment modalities also, that it's significantly affect patients' nutrition status. So it's a kind of a double burden. So we will see that. So when it comes into the disease version, so that we know that cancer is not a kind of a simple disease, it's a multi-organ disease. It's a broad term, that cancer. So according to the tumor location, that side effects or any complaints can be different. So you can see, I think this table will help you to have an idea how this, according to the tumor location, how it affects the commit as a complaint. So I don't want to keep it in a explain again and again. Just show you to keep your mind open, and why this, when we are going to the cancer patients, so why we have to keep as a medical officers that kind of a broad idea when we are managing these patients. So that I told you that the treatment modalities also, it's a very detrimental. It's not a frustrating feeling for the patients. That initially I told that the diabetes usually for the glycemic drugs, that it's not a kind of a that much kind of a problem. But when it comes to the cancer, that basically we are much familiar with the chemo and the radio and the surgery. So you know that, just see with the table, when it comes to the chemotherapy and the radiotherapy, it's a broad spectrum of complications which directly or indirectly affect patients' nutrition status. So it's, as a medical officers, sometimes you might think that I'm not working in the oncology unit or not in a cancer hospital. By the way, now these days, cancer is not a kind of a uncommon scenario. It's a very really common in our setup. So now not only you are working in the hospital, that I think that most of you are in the GP practice or any that kind of a situation. When you are managing another patient also, that there might be a coincide with the cancer. So to give a kind of a comprehensive plan for your patients, I think if you have a kind of a practical tips regarding how to give a kind of a nutritional advice for your patients, really helpful. Because in our setup, not only in our setup, even in the that UK or the foreign setup also, people are really interested, means what to eat or not to eat when they are ill. So if you have a kind of a practical tips, it's really helpful. So I told that there's a kind of a lot of nutrition related problems with the chemotherapy. So why is that? As a medical officers, we know that chemotherapy, that it's a kind of a systemic treatment. Even though there's a cancer, basically we cannot just target on our tumor and we can't treat. So that when we are giving the chemotherapy, usually that initial principle of the management is to destroy cancer cells. So we know as a doctors that what are the cancer cells? That means rapidly that it's dividing cells. So its nucleus is really unstable. So that the chemotherapy target is to that destroy this rapidly that unstable nucleus. So in our body, that our problem is this chemotherapy, it's not itself affect these cancer cells. That's the problem. So especially that we know that in our body, other than the cancer cells, usually our hair follicles, our skin, and especially our gastrointestinal tract, that the epithelium is that relatively its turnover is high. So unfortunately, when we are giving the chemotherapy, what happens? It's basically affect these normal cells as well. So it's come as a side effect. So we all know that usually cancer patients after treatment, that hair loss is a common complaint. So when it comes to the nutrition, when it affects the gastrointestinal tract, what happens from mouth to anus, there's a problem. So that's why chemotherapy, when it comes to the cancer, that's much important to discuss about the nutrition tips. So when it comes to the radiotherapy, it's another aspect. Usually it's a kind of a very, that we are trying to locate the tumor and the treat. So when it go for the focus treatment, unfortunately, that specifically we can't only that focus only for the tumor, that surrounding area, that we cannot 100% assure that the only for the tumor. So it's another problem. Anyway, that with the improvement of the treatment, now more focused radiotherapy methods are there. By the way, that just assume that if you have a patient in your private sector, just assume that now patient is ready to go for a radiotherapy. So patient will ask lot of questions. Then if they ask, so as a GP, you can explain kind of a broad idea what will happen. So usually with the radiotherapy, that after few sessions of the radiotherapy, they develop their complications. And majority of the patients after stop the radiotherapy, just a couple of weeks, that most of side effects we know. But unfortunately, there are several patients that years and years their complications can be there. So as a GP said, you can give that kind of information. Because මට ඒකත් හිතුනේ දවසක් that around now මගේ අර 20 years විතර මම දන්න girl කෙනෙක් ඉන්නවා in my salon, that පොඩි salon එකක් කරන girl කෙනෙක් 20 years කලින් එයා පොඩි තමයි. නමුත් දැන් එයා that now she's have endocrine endometrial CA. So එයාර ගොඩාක්ම ඇහුවේ එයාගේ තියෙන problems. මොකද මට එතකොට තමයි හිතෙන්නේ අපි close කතා කරද්දි තමයි මිනිස්සුන්ට අර ඒ වගේ චූටි දේවල් හරි වැදගත්. ඉතින් අර ඒව කියලා තිබ්බහම මේගොල්ලන් family එකක් එක්ක මේකට ready වෙනවා. So as a to be a kind of a sensitive doctors, these kind of points are really important. අර අපි ලොකු ලොකු theory දැනගත්තට මම හිතන ඒ දේවල් ගැන we have to sensitive. So it is now regarding the radiation induced side effects according to the radiotherapy side. So මම මේක ගොඩක් explain කරන්න යන්නේ. By the way, I just want to highlight here that then just see in the brain that there's a radiotherapy for the brain. Those kind of patients can complain of loss of appetite. You might think it's maybe due to the depression. No, people are afraid of disease. This can be the reason for the not willing for the food. Actually, that patients with the brain tumor following radiotherapy, this can affect their satiety center, and they have a kind of a very deep-seated loss of appetite. So these kind of things are, you have to keep it in mind. So the another thing is the head and neck cancer. It's a thick saliva is a kind of a very frustrating feeling for the patients. And in the later effects, that you have to keep it in mind, that after even years or 1 or 2, 3 years after that, the radiotherapy, they can have a kind of a side effects. Sometimes it's very difficult to relate whether what is the reason for this complaint. For example, that patients, those who are with a history of abdominal radiotherapy for which kind of area, so they can come presents with a chronic enteritis, that means a chronic diarrhea, or sometimes features suggestive of intestinal obstruction. So, and the esophageal stenosis, that kind of a complaints can be there. So if you know this kind of a background knowledge, that what's the helpful is, you can reassure your patient, because that we all know that cancer patients is always, they have a kind of a anxious feeling that මේක ආපහු වෙයිද ඒක දැන් මේක මතුවේද ඕක තමයි ජීවිතේ. ඉතින් අර ඒක අයින් කරන්න මම ඒවා අයින් කරන විදිහ හොඳටම දැක්කේ ඇත්තට UK වලදී. මෙහි අපිට ඒ වගේ සිස්ටම් එකක් නැහැ. ඉතින් that everything that important is the quality of life. මං කියන්නේ හෙට මැරුණත් ඒ වෙනකන් quality of life is the important. අවුරුදු 90ක් 100ක් මේ ඇවිද ගන්න බැරුව ඉන්නවට වඩා දැන් සමහර අය අර ඒකේ ඉන්න කාලේ යාගේ quality of life is really important. Actually we can do lot of things to improve that, reassure and to that improve their personality, that were thinking pattern. So may wage දේවල් that we can tell as a GP, that if there was someone is complaining of a feature suggestive of dysphagia, they might think this is a recurrence of the cancer. So so as a MOs we can tell it might be a problem with your previous radiotherapy, so we better go and refer your cancer clinic. ඉතින් ඒකත් එක්කම කියන්නේ recurrence එකක් වෙන්නත් පුළුවන්. එතකොට මේ patients ලා මාර විදිහට හිතනවා මගේ GP මාර educated එයාට මාර මොලයක් තියෙන්නේ මේ ඉන්න consultant ආවත් එයාට වැඩි knowledge එකක් මෙයාට තියෙනවා. මොකද එයා ඒක ගැන දැනන් යන සමහරකට clinics වලට ගියාම මේක මේ ආයි recurrence එකක් නෙමෙයි මේක තමයි problem එක කිව්වහම මේ patients ලා හරිම ඒකට හරි ඒගොල්ලෝ කැමතියි. ඒ කියන්නේ මගේ GP ගැන they have a kind of a trust. So I think these kind of a simple things we have to keep it in mind. So by the way that I'm here to just to discuss about the more practical points. So I thought to go for a kind of a selected specific cancer related common complaints and to little bit give kind of a practical tips to you. It will helpful for you or even not for your patients or kind of a relations or in people in your village. Then babagi school in කාගේ හරි අම්මගේ මොන හරි වෙලා තිබ්බත් අපිට ඒවත් එනවනේ ඒ වගේ දේවල් වුණත් it will be helpful. So that we will go with the first one. It's anorexia. Now you might think හරිම common එකක් නේ ඔක අහන්න දෙයක්ද any disease that anorexia is a common thing. But please keep it in mind when it comes to the cancer, anorexia is not just a simple loss of appetite. So it's a very deep seated, it's that tumor markers driven complaint. Actually these kind of patients they don't like to even discuss about the food. එක තමයි අංක එක. That once that around 10 years back as a MO nutrition I worked in a cancer hospital for 2 years. ඒ කාලේ තමයි ඇත්තට මම දැක්කේ මට එක example එකක් මතක් වෙන්නේ. This kind of patients they don't like to discuss about the food. දැන් අපිට හිතන්නකෝ මේ patient දැන් family එකෙන් ඇවිල්ලා අපි අද උදේට කිරිබත් කමුද මුං ඇට කිරිබත් කමුද රැයට ඉන්දියාප්ප කමුද අලහොදිත් එක්ක කමුද ඕ වගේම never try to ask. මිනිසුන්ට එතනින් මේක කන්න එපා වෙනවා. මට තාම මතකයි මම මේ පාඩම ඉගෙන ගත්තේ when I was in the cancer hospital in 10 years ago. There was when I'm seeing a patient in it's a visiting hour මේ minor staff lady කෙනෙක් ඇවිල්ලි ඉවරලා මෙතන family එකේ ඉන්න member කෙනෙකුට මේ ගේන මගුලක් ගෙනල්ලා කන්න දෙන්න කියව ඉන්න එපා කියලා කිව්වා සැරේ. ඒක බැලුවහම මම ඉන්නවා කියලා දැක්කේ පස්සේ ඒ lady මට කියනවා මේ නෝනා මේගොල්ලෝ ඇවිල්ලා මේ කනේවා තලගුලිය ඕව ගැන අහහ ඉන්නවා දෙන්නේ නැතුව කිරිබත් ගැන මහනවා දැන් හෙට hospital එකේ අපි දෙන්නේ කිරිබත් මේ මිනිස්සු අතර හෙට කිරිබත් කන්නේ නැහැ. ඒක අද ඉඳන් කිරිබත් ගෑවහම ඒකට හෙට වෙනකොට කිරිබත් එපා වෙනවා. So that kind of things are really practical points. අර දැන් ඔයාලා ජිනදාස තලගුලිද කන්නේ එහෙම නැතුව ඒ ජිනදාස තලගුලියක එහෙම ගෙනල්ලා දෙන්න කියලා තමයි කියන්නේ. ඒක ඇත්තටම මේ very practical point. ඔයගොල්ලෝගේ family එකේ අයටත් ඒක කියන්න ඕනේ. නැත්නම් ඒගොල්ලෝ අපි දැන් හෙට මේක කමුද අපි ආප්ප කමුද ඔහොම එකක අහන්න නැතුව just as a surprise just give them what they want to eat not they want to eat anywhere ඒගොල්ලෝ අහන්න. The another important point in the anorexia is that they can't tolerate these odors, food odors. Then api hitane that when we are getting ill, we need to eat a fresh fruit now. So api ara aluten evelema uyapu gaman rasnen kanna kemathi, but it's completely different in this kind of a patients. When there's a food odor, they can't. Sometimes they themselves refuse to eat. So that practical points that we can encourage them to go for a cook outdoors. But if the patient is in the kind of apartment, we can't give that kind of options. So we can ask them to go for that exhaust fan or that kind of thing. And it's in a village, it's not that much difficult to go for a cooking in outside. And the use of that kitchen fans and when serves the patients when they especially what I saw this thing during my foreign training that before they are offering that their food they always try to open that coverings because that the odor is going out. So and these are the kind of a very practical small point tips. And the another thing that what I saw is keep a fan when they are eating that behind their head. So what happened that their smell is go out. Actually that I'm doing that practice in my Badulla hospital. That's because that means they don't have a kind of pedestrian fan, but sometimes affordable patients I encourage to take that mini fan with the battery driven that eva gave up encourage karna, even though it's a kind of a very simple thing, but it's really doing. Try with your patients. And regarding the taste changes, it's also not an uncommon thing. මේකට ඇත්තට ගෙවල් වල රණ්ඩු වෙන තරම් ප්‍රශ්න. ඒ කියන්නේ දැන් සමහර patients ලා මට complain කරලා තියෙනවා. දැන් මේ මිනිස්සයා ඉස්සර හොඳට chicken කනවා දැන් කන්නේ නැහැ. දැන් කන්නේ කරවල කියනවා. And ඉතින් අර දැන් ඇත්තටම මට මේ real මේකක් මේ patient කෙනෙක් හිටියා දැන් එයා දැන් chicken කන්නේ කියලා කරවල හදාගෙන but on the next day he can't eat dried fish. මොකද that the taste difference also not a for the until his disease period. It also can be changed day by day. ඒක දැන් අද දැන් උදේට බෝංචි කන්න පුළුවන් දැන් දවස් දෙක තුනකින් බෝංචි පේන්න බෑ. ඉතින් අර ගෙදර මහා වලි ඉතින් අර මේ මොකද්ද මේ මිනිස්සයා කරන්නේ මගෙත් එක තරහට වෙන්නේ නැති ඕ වගේම අර so that you have to kindly explain for the family. So and ගොඩක් වෙලා යන්නේ නැහැ දැන් and also that they can have a metallic taste, especially that if they use that metallic things to cook their food and අර සර්ව් කරන්න එහෙම හැඳි පාවිච්චි කරද්දී ඒකෙන්න පුළුවන්. දැන් 2 weeks කලින් honestly ඇත්තටම මට මේ බදුල්ලේ patient කෙනෙක් ආවා. ඒ කියන්නේ husband and wife. දැන් මේ husband අර හැමදාම හොදි බෙදන අර රිදි අර අපි normal spoon එක තියෙන ඒ හැඳි වීසි කරනවා. ඒව එපා කියලා. ඒ හැඳි රහ එනවා කියලා. පස්සේ දැන් මිනිස්සු අර එක එක විදිහට දැන් when there's a cancer that they do lot of treatments. ඒතර මේගොල්ලන් අර horoscope බලන්න ගිහිල්ලා දැන් that usually it's not an uncommon thing go for the horoscope no. ඒක ඉතින් එක කමක් නෑ ඉතින්. ඊපස්සේ දැන් හැබැයි මං confused උනේ horoscope බලලා ඇවිල්ලා කොහොම හරි ඒකත් නිකන් multi disciplinary team එකක් වගේ horoscope එක විතර නෙමෙයි යකදුරේකුත් දෙන්නේ. ඒ කියන්නේ horoscope එකකුත් තියෙනවා යකදුරේකුත් ඉන්නවා. මේ දෙන්න එකතු වෙලා දර හැදි පේන්න බැරි මේ ඒවර මේ රිදී පාට නිසා මේ ගුරුගේ අපලයක් තියෙනවා. ගුරුගේ අපල තියෙනකොට රත්තරන් පාට තමයි හොඳ, රිදී පාට හොඳ නෑ කියලා. සෙනසුරු අපල වලට තමයි රිදී පාට කියලා. කොහොමද හැඳි අයින් කළා මේ මිනිස්සු පිත්තල පාට හැඳි අරගෙන මේ කහ පාටට වෙනවා. මොකද රත්තරන් පාට බල්ලගේ දම් වල පවා වෙනස් කරලා. ඊට පස්සේ මේ ඒ කියන්නේ මේව ඇත්ත කතා. ඒ කියන්නේ what happened දැන් මංගාවට හැම දැන් පිත්තල එකත් මේ මිනිස්සුගේ මේ disease එක නිසා නෙමෙයි. ඉතින් ඒකටත් පිත්තයි. දැන් මේ දෙන්න ගහ ගන්නවා. පස්සේ අන්තිමට මම දැන් ඕක බොරු එහෙම කියලා ලොකු තේරුමක් නැහැ because we have to address according to their IQ. ඉතින් මං කිව්වා ඔව් එහෙනම් මේ ගුරු එක්ක යාළු වුණාට සෙනසුරු තරහ වෙනවනේ ඒක නිසා ඔයගොල්ලෝ ප්ලාස්ටික් හැදි ගන්න කියලා. සමන්තර දෙකම මමත් multi disciplinary team එකට ගිහිල්ලා අර ඒ වගේ සමහරකට this is not to apply for the UK setup. By the way in our setup we have to do that kind of a thing. So take too much time. And is another very frustrating feeling is a dry mouth. So when you are managing dry mouth, actually these kind of very small tips are really important. That sip water throughout the day. ඕක ඉතින් කියන්න දෙයක්ද කියලා හිතෙන්නේ හැබැයි ඔයගොල්ලෝ ඒක කියන්න. Otherwise they don't know. And also that ask them to rinse their mouth every 1 to 2 hours. ඒවා කියන්න. Otherwise they don't know. එතකොට and the chewing gum and use of ice pops or ice chips. Especially අර ice cubes වලට අර toothpick එකක් වගේ ගහලා කටේ තියාගෙන සූප් කරන්න if they like watermelon taste අපිට watermelon juice එකක් ඒ වගේ දාලා මොකද ඒ වගේම නම් අපිට even in hospital setup කරන්න පුළුවන් actually in Badula that we are doing that kind of thing and also that there's a lip dryness is a kind of a problem Vaseline apply කරන්න කියන්නේ මොකද ඒව ගොඩක් ගණන් නැහැ so that kind of a small tips are really important for these patients. And the another thing when it comes to the dry mouth, what happens? It's very difficult to swallow. No, it's very that ඉස්සර රොටි කන්න පුළුවන් එක්කෙනෙක් දැන් රොටි කන්න අමාරුයි. එතකොට so that kind of things we should have a kind of a food list. What kind of things we can give for this kind of a patients. මොකද අපිට ගොඩාක් වෙලා නැහැනේ patients ලත් එක්ක කතා කරන්න. PP එකක වුණත්. ඒතර if you have a kind of a practical that it also should be a kind of a practical thing for your setup. This is around Kandy. I'm not much familiar with the Kandy that I know about the around Colombo area and I have worked in the Sabaragamuwa and now this is in the Badulla. So that according to that that area that අපි දැන් බදුල්ලේ ගිහිලා that scrambled eggs කිව්වට they can't understand no. එතකොට අර ඒ වගේ ඒගොල්ලන්ට sensitive වෙන විදිහට I have to tell. හැබැයි මම ඒක කිව්වා ඒකත් සමහරක් වෙලාවට හරියන්නේ නැති වෙලාවල් තියෙනවා. Then what happened when I practice in the cancer hospital in Badulla it's around now it's almost 1 year. It's only 2 weeks after my point to the cancer Badulla hospital. What happened in my clinic there was several oncology patients. One patient she was around 78 years old lady and there was a major problem was a dry mouth. So when I'm giving kind of a food options for as a now consultant දැන් හැමෝම දැන් කාලයකට පස්සේනේ consultant කෙනෙක් ආවේ කියලා ඉතින් මට විශේෂයෙන් කියලා මේ මූල දාලා දැන් මම බලනවා. So but the lokuවට මේක කන්න මොකද that I have noted when we are advising to take the කුරක්කම් පිටිකඳ කිතුල් පිටිකඳ that kind of things in the cancer hospital patients are really like මොකද අපි නිතර කන දේවල් නෙමෙයිනේ but when I come to the බදුල්ල මම ඒක දැන් හදන විදිහ පිටි පැකට් එක මෙහෙම අරගෙන මේකේ දාලා ඒක හදනකොට හැමතිස්සෙම මෙහෙම මේ හැදි ගාන නැත්තම් ඔක කැටි ගහනවා ඒවත් කී පැය ගානක් කියලා no any interest patient උතලුව කහනවා දැන් කොයි වෙලේද යන්නේ වගේ බලන් ඉන්න පස්සේ after all that I just asked with my MO he was a very senior MO very practical person අයියා what happened that patient was not seems very interest කියලා මම ඉතින් ඇහුවාම ටිකක් hina වෙලා යා දන්නේ නැණි මගේ විදිහ කොහොමද කියලා එකපාරට මුකුත් criticize වගේ නොකිය මේ මැඩම් මේකයි මෙහෙ මිනිස්සු ඉතින් හැමදාම උදේට කාලේ ඉන්නෙත් ඕක තමයි කියන්නේ මේ නිකන් අවුරුදු 10ක ළමයාත් ඔය කුරක්කම් පිටි ඒව හදන විදිහ දන්නවා ඉතින් so අර එතකොට මම that following ඊට පස්සේ මම ගොඩක් ලට හෙට දැන් improve කරන්නේ ආච්චි අපි French toast එකක් කමුද වගේ so ඔයගොල්ලෝ කිව්වට now it's even my nurses they don't know kind of that kind of අර පොෂ් නමකින් මේව කළා ඉතින් French toast කියන්නේ කිරි වීදුරුවකට විතරක් කඩලා දාලා සීනි චුට්ටක් දාලා ලුණු චුට්ටක් දාලා කොහොඳට කලවම් කරලා පාන් පිටි දෙකක් විතර ඕකේ පොඟවලා අර රොටි හදන විතර පෑන් එක කියන්නේ රොටි හදන තැටියට බටර් ටිකක් හරි මාජරින් හරි දාලා ඔක දෙපැත්තේ පැත්ත දාලා ඔයා පැන් රස කැමති නම් පැණි ටිකක් දාගන්න පැණි රස කැමති නැත්නම් නිකන් කන්න එහෙමනේ so that kind of a practical points are really important අපි අර exam එකේ අර ගිහිල්ලා අර මතුරුපු ඒවා in practical setup it's not sometimes it's with the වයසට මට තියෙන එක කැමැත්තක් තමයි අර with experience we learn lot so these kind of things are the really important things what I feel but this is regarding the mucositis I'm not taking too much time so there's a lot of gradings that if you are wishes to learn that you can go through your phone so when it comes to the grade 4 it's really detrimental it's very difficult to manage even TPN is needed and usually these tips so in one slide it will help you to manage a mucositis patient actually most of the things I grabbed from the when we are managing patients in the cancer hospital so oral hygiene is the number one like because that most fungal infections are very common it's a coincide with the fungal infection so we have to go for a kind of a very effective Dactarin oral gel or something like that but problem these days it's not available by the way that go for a betadine mouthwash and more than that this salt half teaspoon that baking soda half teaspoon with the water this solution is really helpful so and also that proper hydration is number one and also I have noted in cancer hospital nurses I couldn't find any evidence that nurses advise for patients to keep a kind of ice cube under their tongue or in the mouth when they go for the chemotherapy අර ඒකට vasodilatation එකෙන් blood flow එක අඩු වෙලා that oral අර කටේ තියෙන side effects අඩු වෙයි කියලා ඒගොල්ලන් assume කරනවා so I'm sorry that it's not evidence based one by the way regarding nausea I know that you all know about how to manage a nausea practical tips it's like we all know that that morning sickness ladies after pregnancy they're having kind of a bad nausea and the vomiting feeling so that we are advised to give a crackers or හුලං විස්කෝතුව whatever මොකද දැන් healthy මට මුලින්ම කියන්න අමතකුණා අර අපි හැමතිස්සෙම නියුට්‍රිෂන් කොහොම බුදුහාමුදුර healthy balanced diet එක කන්න ඕනේ නැත්නම් ඉවරයි වගේ එකක් තියෙනවනේ ඒව නම් කවදාකවත් try කරන්න එපා for especially for the cancer patients those things are depend on the level of the cancer this is not the time to discuss that sort of thing ඒක නිසා අර මුකුත්ම කන්න බැරි ඉන්න මිනිස්සයාට ඒගොල්ලෝ කන්නේ මොනවාද ඇත්තටම පුන්නකු කන්න කැමති කිව්වනම් මම නම් ඒක උනත් ඕකේ කියලා that I learned it from the UK මොකද ඒගොල්ලෝ හරි ප්‍රැක්ටිකල් මැනේජ්මන්ට් ඒගොල්ලෝ කරන්නේ ඒ නිසා අර ඒ වගේ දේවල් අර දැන් මොකද අපි සමහරක් වෙලාවට දකින්නවනේ දැන් කැන්සර් එක හැදුනේ දැන් සමහරක් වෙලාවට මෙයා මේ සොසේජස්ම කාලා කොකා කෝලා බීලා කියලා දැන් හැදුනට පස්සේ ඒකට ඒ මිනිස්සුන්ට දැන් වද තීලා බැනලා වැඩක් නැහැ නේ මෙයා බීලා මේක හැදුනා so that කියන්නේ ඒ පස්සේ ඒ මිනිස්සු සෆර් කරනවා now he is a patient ප්‍රභාකරන් උනත් අපි ගාවට ආවොත් එතකොට patient. ඒතකොට ඔයා මරලා ආවි කියලා එතන බැනලා that as a doctors we have to manage for that patient. so ඒ නිසා අපි practice කරද්දී අර මිනිසුන්ට ගොඩාක්ම වද දෙන්න එපා මේ healthy balance ම කන්න කියලා. එතකොට අර ඒ වගේ tips especially when it come to the nausea we have to and please keep it in mind sit up and prop up for at least 1 hour after eating. Especially that after the cancer, it's a kind of a huge psychological burden. Most patients are depressed and they are mostly confined to their beds or chair. So that with this sedentary feeling that they feel more nauseous. So we have to remind them. This is the reason we are asking you to walk. Otherwise they don't know. Prevent constipation. I'm not taking too much time. You know. but here also walk and do the regular exercise is really important. A regular exercise කරනවා කියන එක ඇත්තටම ඔයගොල්ලෝ practical gym එකකට යන්න කියන එක නෙමෙයි. සමහරට ඇවිදින්න බැරි එක්කෙනෙක් නම් even sometimes that even in my clinic I ask them to do that. අපි හිතමුකෝ වයසක එක්කෙනෙක් නම් if they do this kind of thing that you have to keep your hands and without keeping your back pains, so they have we can ask them to do this kind of very simple exercises. එක්කෝ දැන් ඒගොල්ලෝගේ ධනිස් රිදෙනවා නම් අපිට මේ පුටුව උඩ ඒ කියන්නේ කේතලේ රත් වෙනකන් හරි පුටුව උඩ වාඩි වෙලා අර වැඩි කොට්ටයක් කකුල එල්ලගෙන කරන simple exercises. Usually that in Badula there's a very nice physiotherapy team. So when we are refer these our patients to them, they are giving kind of a very simple thing. එයාගේ family ඒ කියන්නේ එයාගේ normal ඒ life එකේ තියෙන ඒවත් එක්කලා එයාට හරියන දේවල් ඒගොල්ලන් දෙනවා. ඉතින් so that kind of things also really important to prevent constipation. And I think that's not complete this presentation if I don't remind about the neutropenic diet. That means neutropenia is not an uncommon thing with the, especially with the chemotherapy. So by the way, there's no kind of a neutropenic diet. That universal precautions are really important. So, and no raw eggs, no half-boiled eggs. That raw eggs not only for the cancer patients, anybody, there's no place for raw eggs now. So that හොඳට උයන්න ඒ ටික තමයි. And the another important thing is regarding the mold, that fungal infections are really problematic in these patients. Even though these ratakaju, that kind of things are not a problematic for a normal patient, but the severe neutropenic patients, it can be give rise to kind of a very systemic detrimental fungal infection. So you have to keep it in mind. අර එළියේ තියෙන අර fruit and nut cake එක කන්න එපා කියනවා. මොකද ඒ fruit and nut cake එක ඇතුලේ තියෙන අර fungus එක මේගොල්ලන්ට හොඳ නැහැ. කෙසෙල් ගෙඩිය කනකොට අර නැට්ට කැඩිලා වගේ නම් don't encourage them to eat. අර ඒ වගේ පොඩි පොඩි practical tips කිව්වේ නැත්තම් දන්නේ නැහැ. සහ ඒවා really needed. එතකොට අර ඒ වගේ අනික මයික්‍රෝවේව් එකක් තියෙනවා නම් අර එළිය ගොඩක් වෙලා තියාගෙන දාන්න එපා. ෆ්‍රිජ් එකෙන් අරගත්තට පස්සේ නිවෙනකන් තියාගෙන ඉඳලා රත් කරන්න එපා. ගත්තොත් ලිපට තියලා රත් කරලා කනවා. And we have to encourage them to consume that thing within 24 hours. Refrigerate කරලා තියාගන්න පුළුවන් 24 hours විතරයි. So these are the practical points. So this is the last 3 slides. Don't worry, I'm finishing now. So when that we cannot finish cancer management without talking to the palliation. So when it come to the palliation, what happened? That you අපි දැන් hospital එකේ දැක්කනේ මෙයා palliative කියලා ඔන්නේ අතහැරලා දාලා වගේ කන palliative කිව්වොත් ඉතින් ඕන දෙයක් කමක් නැහැ වගේ feeling එක. No, it's not like that. Palliation means that these people can die within minutes or within 1 day or within weeks or sometimes years and years. So first of all, if you have a referral from the palliative patient, just ask from the oncology team what is the phase of the palliation. Whether is it a phase 1 or 2 or 3. So if it is a phase 1, that means the patients have a life. So we have to improve their quality of life. So and the phase 2 means they are basically imminently dying patients, probably few weeks or that kind of thing. So phase 3 is patient is dying. So when in the phase 1, so now he has to survive more than months and years. So in this place, in the nutrition, actually even parenteral nutrition also indicated according to the patient. So we have to discuss with the multidisciplinary involvement is really important in this kind of a patient. And when it comes to the phase 2, what happened? Now patients are really dying. Probably patient is expected to die from the tumor progression rather than the starvation. So this kind of patients, that quality of life and their feelings are the most, that communication skills are really important actually, but never ever try to ask them to wait where අර බර බලන්න ඒව නම් හිතන්නවත් එපා. So අර කන්න කැමති ඕන දෙයක් කියන්නේ මේ වෙලාවට තමයි. But I noted in UK that even alcohol, that සමහරකට drinks අරගෙන අර ඩෙත් වෙන ඕන වගේට එයා මොන කන්න කැමති බොන්න කැමති වෝඩ්කාද රාද මොකද්ද කියන එක ඒගොල්ලෝ කැමති නම් then offer කරන්න කියලා තමයි තියෙන්නේ. අර එයා enjoy කරන්නේ මොකද්ද ඒක දෙන්න. මිසක් අර මේ වෙලාවට කොකා කෝලා බීලා තමයි වාට මේ කැන්සර් එක ආවේ, මැගි නූඩ්ල්ස් කාලා තමයි කැන්සර් එක ආවේ කියලා අර වද දෙන්න එපා. So when it comes to the phase 3, now it's a dying phase, we know there's no place for the nutrition. That just a communication is the important with the family. So I think I'm not going to, this is the last slide. I don't think we need to discuss about this part. So we will go for the next lecture. Thank you so much for listening.
I'm actually Dr.Gawri, Samarasekara, nutrition physician at Ragama. and my friend, due to unavoidable reason, she couldn't attend to this lecture today. So I will try to do my best to deliver this lecture. So this is regarding perioperative nutrition care. So what is the aim of the perioperative nutrition care? It's to return to normal function with full recovery soon and smoothly as possible. So why? Because the surgery itself is a trigger many physiological and metabolic responses, and that ultimately increase the catabolism. So what are the stressors in surgery? So stressors multiple, as you can see. I will not go through everything, but the pain, even the anesthesia, hypoxia, overhydration, dehydration, starvation, tissue injury, and multiple causes for the stressors in surgery. So what happens is, when there's a tissue injury and pain, that secretion of mediators in metabolic response, especially the stress hormones, catecholamines and cortisol. On the other hand, the interleukin 6 tumor necrosis factor, that the inflammatory cytokines, what they do is they all increases the insulin resistance. So insulin itself is an anabolic hormone. So when there's resistance, what happens is the muscle protein synthesis and fat deposition will be not there, and the breakdown of muscles and that muscle and fat breakdown and catabolism will occur, and that will increase the delay in recovery. So as you can see that insulin resistance more during an open colorectal surgery rather than the laparoscopy. That means the minimal invasive procedures will reduce the insulin resistance and increase the insulin sensitivity. So what are the surgical stress-related hyperglycemia due to insulin resistance? It's as same as diabetes, because insulin resistance and glucose metabolism in diabetes type 2 and in post-operative patients, as you can see in this slide, it's the same. So the changes in surgery induced glucose metabolism can occur within minutes to hours and complications within days. So to overcome that is the ERAS guidelines play a major role. So what is ERAS? So since there are so many medical students, I think if you know that name, and as the take-home message, if you know that there are guidelines for enhanced recovery after surgery, that's enough, I think, as the take-home message even. So the principles of enhanced recovery after surgery will be discussed hereafter. And when you say perioperative, it's pre-op, intra-op and post-op. So pre-op, the prehabilitation. That means you are preparing the patient for the surgery. So as the previous speakers correctly said, so always you have to relieve the anxiety, and you have to optimize nutrition and exercise to induce muscle anabolism is something that you can help the patient to reduce the stay and reduce the morbidity and mortality. So what are the key steps in prehabilitation? That is, if you can keep it as a new method. New means N means nutrition, E means exercise, W means worry reduction. So when you preparing a patient for the surgery at your clinic, so it's better to refer the patient for nutrition, for exercise. There are specialists in current field, and worry reduction. That means the psychological counseling. And top of that, anemia correction, cessation of smoking, alcohol, all these things take a major role. So how to optimize? So since we are talking about nutrition today, how to optimize the nutritional status, as itself is a prognostic factor in surgical patients. So screening, I will not go into details because everybody talked about the screening. And so if there's a severe risk of malnutrition, so immediate that they are the markers, actually weight loss more than 10 to 15%, BMI if it is less than 18.5, and the nutritional screening tools, the the score is more than 5 and SGAC and the albumin levels less than 30, severe metabolic risk is there. So how are you going to prevent or preventive strategies to reduce metabolic stress response? So currently, if the patient has any nutritional deficiencies or calorie deficiencies, so you have to correct it. And immunological preconditioning, I think previous speakers, especially Nalinda, told about the immune enhancing immune preconditioning formulas related to the surgery preoperatively and metabolic precondition. That is carb loading. I think he already told about that. So these are more advantages for at risk and elderly, frail or malnourished or cancer or immunocompromised patients. So these are the simple tests. I think everybody told how to optimize calorie intake, and if not tolerating liquids, how are you going to give it by supplements and enteral tube feeding if the patient is not tolerating any oral, or if they cannot take orally, or parenteral nutrition as appropriate. So protein must be optimized with goals, but energy via carbohydrate and fat must be first optimized. Micronutrients should be provided whenever required. Deficiencies should be corrected, and if there's no any deficiency, you have to give the RDA. So immunologic precondition, the P of immunonutrients. So I'm not going to tell what are the immunonutrients because previous speakers spoke about immunonutrients. So if you can give immunonutrients 5 to 7 days prior to the elective surgeries, especially the major surgeries, according to the ERAS protocol, that the in ERAS, that enhanced recovery enhanced recovery after surgery can be expedited. So metabolic preconditioning, so you can give carb loading, that is to reduce the fasting time, because earlier I mentioned the stressors. The starvation is one of the major stress to prolong the recovery. So 2 hours before you can give non-alcoholic clear liquid. 6 hours before you can give liquid meal or soft diet. 8 hours before you can give a solid or fatty meal. So how this preoperative carb loading works? So it attenuates the catabolic response induced by overnight fasting and surgery, and reduces the post-op insulin resistance, and reduces the protein catabolism, and maintain the lean body mass and muscle strength, and it has beneficial effects on cardiac, heart, and faster surgical recovery and better post-op well-being. So this is how you take 12.5% maltodextrins and take 100 grams into 800 ml of water and giving evening before the surgery, and 50 grams in 400 ml water giving 2 to 3 hours before the induction of anesthesia. So currently in Sri Lanka there are these pre-op carb loads are available, but as a poor resource country there are options because everybody cannot afford for carb loading. So even if you can give king coconut water, lime, orange juice, or plain tea or coffee, even ORS, these can be, I think, tailor-made. Most of the patients, they take narang juice or something like that. So that will be beneficial to these patients to reduce the insulin resistance. So the other thing is correction of anemia. So I will not go through it because correction of anemia is the key to reduce the tissue hypoxemia and enhance recovery. So, what are the other factors in prehab? As I mentioned earlier, exercise, pre-op counseling, psychological preparation, and cessation of alcohol and smoking at least 4 weeks before the surgery, and screen for disease and optimal medically. So, when the post-operative day one, most of the time we see the patients in the ICU with high blood glucose levels, because the guideline says you have to maintain that between 140 to 180, but most of the time we see higher numbers more than this range. So how that insulin therapy is the key to uh, control the blood glycemic control. So then the fluid management, you have to avoid dehydration and you have to avoid overhydration as well. And goal directed fluid therapy is the best to the reduce under perfusion with hypoxemia and overload, the loading to the gut edema and anastomotic complications you have to avoid by giving the goal directed fluid therapy, pain management and minimally invasive surgery. So then we'll talk about the post-operative ileus a bit, and definition is the transient cessation of coordinated bowel motility after surgical intervention, which prevents effective transit of intestinal contents or tolerance of oral intake. So recurrent post-operative ileus is the concurrent occurrence of ileus after an apparent resolution of the immediate post-operative POI. So prolonged POI is, it is more than 3 days for laparoscopic surgery if it is more than 5 days for open surgery. So what are the causes or risk factors? So increasing age, male sex, low preoperative albumin, acute or chronic opioid use, so previous abdominal surgery and pre-existing airway or peripheral vascular diseases, long duration of surgery or emergency surgery, and blood loss and need for transfusion and procedures requiring stomas. So how are you going to prevent? So early enteral nutrition will prevent post-operative ileus. So that is the key, I think, the take-home message for you all. If especially if you are working in the ICU, the early enteral nutrition initiation will prevent post-operative ileus. So other than that, use of chewing gum, goal-directed fluid therapy, reduce the use of opioid analgesia, and correct electrolytes, and early mobilization, early removal of NG drains and catheters, because that will help early mobilization, and use of prokinetics. So post-operative nutrition, I think the most important, as I mentioned previously, as early as possible. And the advantages, it has a stimulatory effect on the gut, maintain gut integrity, and maintain the gut-associated lymphoid tissues, and prevent leaky gut syndrome and systemic bacteremia. So if enteral nutrition is not possible or contraindicated, you can go for parenteral nutrition. So monitoring, as previous speakers mentioned, clinically, biochemically, you have to monitor the patients as in ICU. So follow-up, there should be a routine follow-up and monitor intake and biochemistry, and we have to adjust appropriately. Thank you.
Good morning, all of you. And actually, renal disease is another aspect that we need to know the right nutrition. Otherwise, patient will go into a lot of restrictions, especially in terms of proteins and then potassium, likewise fruits and all, and then ultimately end up with malnutrition. Anyway, the renal disease contributes to malnutrition. I will explain it in my lecture. So that right nutrition advice needed rather than lot of restrictions. That is my starting point. These informations are based on recent guidelines and evidences, and as well as with my experience with my patients. So this is the outline of the presentation. Metabolic changes in CKD, causes of malnutrition in chronic kidney disease, and assessment. I'm not going to elaborate more on that because you have learned about nutrition assessment in the previous lecture, and nutrition requirement and diets in CKD, and parenteral, place of parenteral and enteral nutrition in CKD. So as you all know, this is the classification of CKD according to kidney disease global initiatives. So then, as you can see, according to the GFR, we classify kidney disease into 1, 2, 3, like 3A, 3A, 3B, like that. So that end stage renal failure, so like less than 15 GFR. So likewise, the nutritional management also depends on the level of kidney function. So why nutrition is really important in kidney disease? You can see protein catabolism is increased due to various reasons, and you can see in this graph when the GFR is going down, the frequency of protein catabolism is more. So, and more elaborative on that. So chronic kidney disease is a chronic inflammation in the body, so you can get a lot of inflammatory markers, and then when these patients undergo therapeutic interventions like dialysis and all, there are anyway the catabolism again increase, and also these patients have uremic toxins in their body, and then metabolic resistance, so all contribute to reduce energy intake and as well as increase catabolism, thereby protein energy malnutrition. So according to the latest data, at least 30 to 50% of patients who are diagnosed with CKD are diagnosed with protein energy wasting, and it can go up to about 75%. So and as well as when the patients are on dialysis, especially if the patient or the CKD patient is with protein energy malnutrition, so the mortality is more. So how can you assess the nutritional status? Same as by as my colleague said, with specific nutritional assessment tools. There are some specific nutritional assessment tools for kidney diseases. I'm not going to elaborate more on that, but as you can see, the basic criteria for them are, most of them are like weight loss, recent weight loss, BMI, level of eating, those criteria. So, and also we can evaluate like comprehensive assessment, like as Dr. Jayaweera explained, like anthropometric, biochemical, clinical, and dietary assessment, and also by these tools. Sarcopenia is another very important factor that we come across in these patients. Sarcopenia and protein energy wasting differ from one another. Sarcopenia, actually, it's related to muscle strength and muscle quantity and quality and the physical performance. So that in these patients, the risk of sarcopenia is also more. So considering of all these metabolic and these metabolic and hormonal and everything related to this CKD, when you encounter a patient to prescribe a nutrition plan, we come across these problems. So wasting and sarcopenia, then these patients are always most of the time hyperkalemic and hypophosphatemia, acidotic, and anemia, then poor diabetic control. So when you give a plan, we have to get all these things in the challenge. So what are the nutrition requirements, especially when it comes to protein? I would give this. This is the CADOC guidelines. It is 2020. So I will compare two guidelines and show how the protein requirement differs and how the protein requirement should be advised. So in this guideline, as you can see, energy they have mentioned like it is a bit of a more energy than a normal person. And when it comes to protein, the stage 3 to 5 patients, so it's around 0.5 to 0.6. Our protein requirement is, normal person's protein requirement is 0.8 to 1 gram per kg. So then they further advise, like if you go for further lower protein targets like 0.3 to 0.4, like you can combine them with keto analogs. Keto analogs are these commercially available products. So there are some products to combine with this low protein intake. Then if you have CKD plus diabetes, bit of a higher protein requirement is advised. Then sodium requirement, it's really, we have to restrict to sodium, so it is less than 1 teaspoon per day, 2.3 grams per sodium. Then potassium, they have mentioned to be adjusted to maintain adequate serum potassium level. So it is depend on the serum level, and phosphorus also depend on the serum level. And then attention for avoiding low intake levels, like regarding fiber. Then dietary patterns, they have mentioned about Mediterranean type diet, that's plant-based diet. That means not eating much of red meats and things, plant-based. You combine plant protein as well as animal protein as well. Then fluid restriction usually not needed for pre-diabetic patients. So this is one of the major guideline in system. And the next one is KDI this Global Initiative Kidney Guidelines. It is 2024. They have not clearly mentioned about energy. It's depend on the patient's BMI and activity levels and all. Then protein, you can see they have given a bit higher target, like even for stages 3 to 5, they have given 0.8. And if you combine with keto analogs, they have mentioned 0.3 to 0.4. Then so CKD at risk of kidney failure, consider higher protein intake, and also in old adults they are asked to go for a bit of a higher protein intake. So what my point that I have to elaborate here is, usually in our population, our people, our normal population, they don't eat much protein like Western countries. They don't eat big steaks and all. So that when you advise, like generally not to eat protein, not to eat like that, that is really they will reduce further their protein intake. Usually, actually, when you can count our protein intake, generally it comes to levels equal to this protein target. So that when you advise patient with kidney disease regarding protein intake, you have to be very cautious, and you can give clear advice that not to restrict much. So even for these stages 3 to 5, international guidelines, they have advised to give adequate proteins. So then sodium and potassium, of course, they have advised similarly as Gadaki, and also potassium also. So when we come across these patients, they said that doctor said not to eat foods and all. So they have specifically mentioned avoid foods rich in bioavailable potassium, like processed foods, packaged food, tin foods. Especially they should be discouraged, rather than, and also very high potassium foods like bananas and king coconut water things. Otherwise, not to say generally not to eat foods like that. So that's my actually take home message. And then for prosperous also tailor diet according to their individual needs. Then so then patients who are on dialysis, those are the protein requirement patients who are not on dialysis, stage 3 to 5. So then this is the protein requirement patients who are on dialysis. So it goes more than the normal protein requirement of general population. So it goes up to 1 to 1.2 or maybe 1.4. So that is the message here. Then what about hospitalized patients? When you come across the hospitalized patient, you come across patients, CKD patients with acute illness, so that don't restrict much protein, so you can give the normal protein requirement that they are tend to be. Then hospitalized patients with CKD on conventional or treatments, maybe critical illness, you can critical illness or maybe renal replacement therapy, you can go for higher protein requirement. Then hospitalized patients with AKI, so you can start AKI on CKD patients or ICU patients. ICU patients may not be having CKD but may be having AKI due to other reasons, so that actually they can be given the normal protein requirement that the ICU patient can be given, like 1 to 1.3. So you can start safely in CKD patient like 1 gram per kg, then gradually increase. It's for short term. Then what is the protein type? Still no clear evidence. They advise healthy diverse of proteins, like mixture of animal and plant protein. Like plant proteins are rich in legumes, beans, nuts, seeds, whole grains, then starchy vegetables and breads. So then meat proteins, as you all know, poultry, fish, seafoods, eggs, like that. So go for mixture of that. That is the basis of plant-based and Mediterranean diet. So go for a diet like that. Actually, our normal Sri Lankan diet is just like a diet that close to Mediterranean and this plant-based diet. We don't eat much protein, like we focus on fish and some dal and then some gotukala sambal and slightly cooked vegetables, so that you can slightly advise to reduce maybe carbohydrate portion if the patient is obese, and to reduce much of coconut like deep frying and things, but generally our Sri Lankan diet is closer to this type of diet, which are advised in international guidelines. Then the other thing is sodium. So definitely you need to restrict salt. So avoid food items high in salt, like packet foods, junk foods, and also the sauces, pickle, dry fish, salted nuts. Those things should be discouraged. Then methods to reduce salt is really important, because when you take dry fish, patient can be asked to soak them in boiled water or coconut water for about half an hour and drain the water and wash it again and then cook. So avoid processed meat and processed food, and then use fresh fruits, and then we can take lime instead of sodium to improve the taste. So these are the tips. Then when it comes to potassium, unnecessary dietary restriction should be avoided. When needed, the individual advice can be given. Unprocessed food should be encouraged, as bioavailability is higher. As I mentioned, processed foods have high bioavailable potassium, so they should be discouraged. So then even in unprocessed food, when cooking and cutting, we can advise some methods to reduce existing potassium content of this, especially starch foods, potatoes and things. So peel and cut the vegetables into small pieces and wash them with drinking water and put them into a large bowl. Then you can soak them in a water content, about 4 to 5 times of water content of the vegetable amount, about half an hour to hour. Then rinse them with warm water and then proceed for cooking. So that method will reduce excess potassium. So then rather than steaming the vegetables, boiling and cooking is encouraged, because when you steam, the potassium is preserved. So these are some some ideas for potassium content of these foods. So actually better not to give this whole list to patients. Like I always say that depending on the serum potassium levels and all, you can see the last 3 months of 6 month potassium level and decide how the potassium goes up and down. So like actually if the potassium level is very high, the patient can be advised to avoid very high potassium foods like potatoes, broccoli, bananas, avocados, oranges, those things. And if they are not having very high potassium levels, you can give a mixture of medium and low potassium suggestions. Then phosphorus, actually normal phosphorus intake is 800 to 1000 milligram, and the normal serum phosphorus level is 3.5 to 5.5. So the phosphorus actually also to be maintained according to phosphorus level. Foods rich in phosphorus are like actually the foods that are rich in proteins, especially red meats and these organic phosphorus which are in fizzy drinks and all, to be discouraged. Then nutrition supplementation. Regarding the place of nutrition supplementation, there is a place, as Dr. Nalinda described, there are disease-specific nutrition supplements, kidney-specific formulas. They can be used to uplift the calorie intake or maybe to back up the protein intake of these patients. And if needed, the patient is malnourished and the appetite is really low, we can go for NGO tube feeding. And if there's any necessity, if there's no access to enteral feeding, we can go for supplementary or parenteral nutrition support. So something about interdialectic parenteral nutrition. This is some concept that is going on in practice. When the patients are on dialysis, within the dialysis, some amount of parenteral nutrition can be given during the dialysis period. So this has proven to improve the nutritional status of the patient. And there are some criteria for initiating interdialectic parenteral nutrition, so I'm not going to elaborate more on this. If you can remember, there is something called interdialectic parenteral nutrition. That is more than enough. So in summary, chronic renal failure affects body nutritional status. Energy and protein loss is significant and leads to negative outcomes. Anticipating identification and an early referral can make a positive impact. Dietary restriction should be made cautiously. You have to advise the right, not to restrict. Then low protein diet, low sodium intake and adequate energy intake, predominantly plant-based diet, reduce the CKD progression, uremic symptoms and metabolic complications. Medical nutrition interventions are crucial for long-term well-being. Thank you. If you have any questions, we can discuss later. Thank you.
Yes, so I'm moving from kidney to lung now. So nutrition in chronic lung diseases. So I would first I would like to go for the definition of chronic lung diseases. So according to European Respiratory Society, it's long-term lung conditions that have negative impact on patients' quality of life and activities of daily living. So I would like to highlight the words quality of life and activities of daily living. So lung disease, chronic lung disease is a disease which affect those two important aspects of the life. So it's kind of an umbrella term. So it includes common respiratory diseases like COPD, asthma, interstitial lung disease, pulmonary hypertension, cystic fibrosis and bronchiectasis. But depending on my clinical exposure, so I would like to talk more about the COPD in this lecture. So I would like to go for the prevalence of the disease first. So if we discuss about COPD prevalence, globally it's like 11.7%. In South Asia it's like 7%. Sri Lanka it's 10.5%. It's closer to the global prevalence actually. So if we consider about the malnutrition in COPD patients globally, 30% of the patients with COPD are malnourished, and the other thing is closer to 50% of the patients are at risk of malnutrition. So that means 1 out of 2 patients with COPD are at risk of malnutrition. So this is because this is a kind of a multi-organ systemic disease. As medical officers, you know, it involves almost all the systems of the body. It involves CVS, skeletal muscles, lungs, and psychological aspect also, because this is a chronic disease, most of these patients are depressed. So why do we worry about the malnutrition and COPD or chronic respiratory insufficiency? That's because malnutrition will directly affect the lung functions. What study says, lung function will lower the forced expiratory volume. That means the lung functions. So it worsens dyspnea, it causes poor exercise tolerance, and it exacerbates respiratory failure. And the other thing is, I think you have seen if the COPD patient is intubated in the ICU, it's very difficult to wean from the ventilator. That is because of the malnutrition and associated low muscle mass, and invariably it increases the mortality, reporting the hazards ratio more than 2. So while I was working in the Valisara hospital, I got a spectrum of patients. Some patients are severely malnourished, some patients are obese, some were walking patients, some were critically ill, and there were acutely ill patients and chronically ill patients in the clinic setup, and there are medical patients and surgical patients, especially the thoracotomy patients. So I would like to elaborate more on why this nutrition is that much important in hospitalized patients with chronic lung disease. Why this is this much important? So as I told you earlier, so low BMI is an independent mortality predictor. It causes high mortality, not depending on the disease severity itself. So even though the disease is severe, it also causes the mortality, but as an independent factor, low BMI causes mortality. And these chronic lung disease patients are frequently in a negative energy balance. This is because of the low intake, and because of the dyspnea, their resting energy expenditure is high, and there's an underlying systemic inflammation, and they are dyspneic and causing high energy or high oxygen cost. And there are a lot of reasons for their low intake. So as a medical officers, dyspneic patients can't eat. And the other thing, they feel fatigue when chewing, so it limits their intake. And there are a lot of food fads among them. Some people say eggs are cold things, and some people don't eat dairy products. So there are a lot of food fads among them, preventing them become nourished. And the other thing is, these patients frequently complain of dysgeusia. That means they complain of metallic taste in their mouth. This is because of the cytokine response and certain medications. As you know, they are frequently on theophylline. So theophylline causes bitter taste in the mouth, limiting their oral intake. The other thing that I would like to highlight regarding their muscle loss, when they are losing muscle in these chronically ill respiratory patients, they lose more muscle than fat. So if you want to lower your weight, or if the obese patient lose weight, it's both the combination of fat mass and muscle mass. But these respiratory patients, what studies say, they lose more muscles than fat. So there's a hidden loss of muscle mass. So even though the patient looks normal to us, there's a definite underlying sarcopenia among them. So that is what I would like to highlight. The other thing is, because of this low muscle mass, it invariably causes low respiratory function. They can't breathe, low muscle strength, which causes low quality of life, low exercise capacity. They can't run and walk, and and causes frequent readmissions and early admissions as well. So considering all these things, so I told you the muscle mass is the most important thing in these chronically ill patients. So what are the nutrition interventions that we can do to counteract this malnutrition? It is called pulmonary rehabilitation. As medical officers, I'm sure you have heard that term. It's a kind of a multimodal approach. We don't manage patients alone. So it's a kind of a teamwork with medical staff, nutrition people, physiotherapist, and psychotherapist as well. So, as I told you earlier, this nutrition support itself causes both respiratory and non-respiratory benefits. So, it improves lung function and it improves quality of life as well. And I would like to highlight this fact also. To get a good benefit by provision of nutrition, you have to gain at least 2 kilograms of body weight. So remember that. So to gain good body weight, what we have to do, we have to give good calories, good amount of calories, good amount of protein, especially high quality protein, depending on the clinical situation of the patient. So little bit of a messy slide. So but again, there are some points I would like to highlight. I told you this respiratory ill patients are dyspneic patients most of the time. So what to provide nutrition, we have to stick on some basic principles. So we are going to provide them frequent small feeds. Sips are the best because they are having this postprandial dyspnea. Kapuhama mahansi hati kiyala kiyanawani. So we can give them kind of a formula or soup to sip throughout the day. So it's a good intervention that we can do. And the other thing for the dyspneic patients, we are using kind of a nutrition principle called texture adapted diet. That means if we want to give a fruit, we are not giving it as a all. We mix it with the milk and blend it to make a smooth consistency and give it. So that is called texture adapted diet. So we can use soups, blends, smoothies, those kind of things to prevent or to minimize this postprandial dyspnea. The other thing I would like to highlight is regarding the nutrition supplements. So I think you have some basic idea about the nutrition supplements. So nutrition supplements, what research says, it has been reduced the length of stay and early readmission. So it's beneficial in respiratory disease patients. And but the other thing is we can use our standard nutrition supplements, which Dr. Nalinda correctly said, for the normal patients. But if the patient is on respiratory failure, especially type 2 respiratory failure with worsening hypercapnia, we can go for specific respiratory solutions or specific respiratory formula which contains low carbohydrate, high fat, and good amount of protein. This is because of the RQ value. In fact, RQ value is low. Carbs, RQ value is high. That's why we are going for low carb diet, which produces more carbohydrate than fat. The other thing what I would like to highlight, you have experiences with the patients in high flow oxygen. So if the patient is in high flow oxygen, you know because of the high flow, there's a aerophagia. Air enters to the stomach, causing full stomach. So in that kind of a patients, don't rush and put NG because of the aerophagia, the rovo-esophageal sphincter pressure is low. So on top of that, if we put the NG, then aspiration risk is very high. So if the patient is conscious in CPAP, we can go for comfort oral feeds until he becomes stabilized. But if the patient is not conscious and rational, then we can use a fine bore NG tube to give basic nutrition needs. The other thing, by giving we gave energy protein for these patients. Again, we can't forget micronutrients. So we are generally giving broad spectrum micronutrient for these patients, especially micronutrient supplement containing zinc and vitamin A. And importantly, we have to arrange follow-up for these chronically ill patients. So again, I would like to highlight the most important prognostic intervention is maintain or improve their muscle mass. To do that, you have to discuss with the physician to control the disease with the drugs and give adequate calories, good protein, and introduce endurance exercises. And there are studies saying that fish oil has an anabolic effect on muscles, and sometimes in some studies they have used anabolic steroids, that means testosterone analogs, to improve the muscle mass in COPD patients. Yes. So after this boring theory stuff, I would like to go for some clinical scenarios. I think it would be more interesting. So this is one patient I got from a medical ward in Valisara. She is elderly lady, 85 years. Luckily, she had no comorbidities except COPD. She was acutely ill with acute exacerbation. As you can see, she's just skin and bone. Her BMI was very low, 12. She's febrile. She was an NIV, and she had no fat mass and minimal muscle mass, and her appetite was very low, and she had aversion towards eggs and meat. She was conscious, able to swallow. There was no features of aspiration. but chewing was difficult. She is very severely frail. So as you can see in her investigations, CRP was high. She had anemia. Creatinine was low, low normal range, indicating her low muscle mass. Calcium was low, and magnesium was low, but I didn't have albumin level at that time. Phosphate was normal, sodium was low, and potassium was marginally low. So in ABG, there was no respiratory failure. So what I wanted to do, I took that lady to a front bed and monitoring instituted, because she was in high refeeding risk. She is very, very frail with very low BMI. So because of that, we started on IV timing. Even though calorie target is very high for this lady, we started in a low level and top up. And protein target was also high, but we started in a very low level. We didn't put ANG because her mood is already low. So if we jump and put ANG on that lady, it will be a disaster. So again, we used a texture modified diet. Electrolyte abnormality is corrected, and we gave broad spectrum multivitamin with vitamin D and vitamin C, and omega-3 fatty acids as well. Iron deficiency corrected. And the other thing, as the respiratory distress improved, we mobilized the patient at least to chair, and we gave psychology support for her low mood. So what happened? What happened about 3 to 4 days was her appetite was improved, catabolism halted, and improved general condition. And we arranged follow-up diet with very good calories and proteins with a good review plan. So this is that lady. See, she has been improved a lot, and these are the things that we use to optimize her nutrition condition. In Jayaweera hospital, we have a special soup having high calories to feed them. Okay, so scenario 2. This is a different scenario. It's a young patient, 50-year-old patient with COPD, having other comorbidities as well, bronchiectasis, pulmonary hypertension, and importantly, he was a patient with respiratory failure, type 2 respiratory failure, chronic patient who was on NIV at home. He came with the infective exacerbation with worsening dyspnea, and appetite was very low, and he cannot tolerate fluids at all, solids at all, and he, on top of that, he refused hospital diet because of the safety concerns and religious benefits. So what to give for him? So his mobility is very much restricted. On top of that, because of a DM, he is a patient with nephropathy. So we didn't have any reports regarding his nephropathy stage. So this is the ABG. As you can see, there's a respiratory acidosis with PCO2 70 with type 2 respiratory failure. CRP was high, potassium, sodium levels were normal. He is anemic. The other thing is he is getting frequent hypoglycemic events because of the I think because of the food aversion, or else it might be advancement of the renal disease as well. So what we did, so his BMI was 15. Again, we started nutrition counseling here, which is the most important thing in nutrition provision. So we highlighted him the importance of nutrition, and we respected his to his religious beliefs. And we contacted the hospital food supplier and sorted his issue regarding the halal products. And the other thing, he is severely malnourished patient, again with type 2 respiratory failure. So we gave him low fat and low carb and high fat diet here. And the other thing, again we gave him oral diet, no NGs here, and calorie target or protein target was high. And here we use this low carb high fat meal with the olive oil. The other thing, we got down some respiratory specific formulas as well, and avoided simple sugars because of the diabetes, and fruit and veggies to compensate acidosis. That's also really important. Again, modified consistency meal theory worked here, and we gave enough micronutrients which is relevant to him. So again, multidisciplinary approach, referral made to nephrologist, chest and limb physiotherapy, psychology referral, and arranged follow-up. So So I have removed the photos of him. So again, another scenario, I won't take much time here. So this patient, a little bit of, it's an obese patient, came with the history of acute asthma patient, came with the acute asthma exacerbation. So here, as you can see, patient is breathing from the open mouth. She's dyspneic. So if we jump and advise her for the low calorie diet, she will definitely hit us because she can't breathe. උස්ම ගන්න බැරි මොකද ඒක low calorie diet එකක් කියලා වැඩක් නැහැ. So what we did was we gave her isocaloric and high protein quality diet with micronutrients, and we referred her to our nutrition clinic and counseled for weight reduction diet at the clinic. Right. So those are the clinical scenarios. So again, I would like to take a small time to go for the general principle, general things regarding the COPD diet. This is for us, both for us and patients. So this based on the research, current research evidence. So what research says, prudent diet. Have you heard about prudent diet and Mediterranean diet? So prudent diet says means it's fruit and vegetable diet, lean meat, fish, and healthy fat and nuts and legume containing diet. Mediterranean diet is the same thing, but it has more specification towards the olive oil and fish. So those diet has a positive evidence for preventing and treatment role in COPD and chronic lung disease. So if you want to stay lung disease free, so you have to eat fruit and vegetable diet. This might be because of the containing antioxidants of this food. Especially beetroot has some studies shows that beetroot juice has a positive impact on the lung health. Especially it might be because of the nitrates. So it's evidence based. I have written the evidence at the bottom. Again, we have to take good minerals like calcium, magnesium, food-based things. Vitamin D's, again, there are trials showing that low levels can worsen the respiratory functions. And omega-3 fatty acids, and especially fish, has very positive evidence towards the lung health. So omega-3 supplementation and the fish intake itself improves the lung health. This might be because of the lowering inflammatory markers by those foods. So those are the things to eat for good lung. So what are the things that we can use to that we should not use in lungs perspective? So we have to limit Western type diet, that means cured meat, processed meat, and especially refined carbs. If we consider about the lung health, the other thing, we have to control our blood sugars for good lung. So basically it's to avoid westernized diet. So these are the studies which has been clearly shown that prudent and Mediterranean diet is good for the lungs. So these are enough evidence. So basically this is the summary. So Mediterranean diet improves lung, and westernized diet deteriorates lung functions. Okay, to sum up, chronic lung diseases are common worldwide, relatively common in Sri Lanka. So prevalence of malnutrition is high in chronic lung diseases, and nutrition rehabilitation plays an important component as a part of pulmonary rehabilitation. It's a multimodal approach. We have to talk about the smoking cessation as well. So texture modified small frequent meals orally. Oral route is the best route, tolerates better in dyspneic patients. Oral feeds better than NG in patients if the patient is on high flow oxygen. Low carb, high fat diets for hypercapnic patients with type 2 respiratory failure. Do not rush for weight reduction in acutely ill patients. Prudent and Mediterranean diets are best for both preventive and curative aspects for the chronic lung disease. So read about the Mediterranean and prudent diets for the better lung functions. Thank you very much.
nutrition. So I want you to just forget about listening to another lecture and don't fall asleep, but close your eyes and memorize, visualize your mother, your father. They have supported you, guided you throughout your life. Because of that, you have become a better human being, and you are here as a medical student and a doctor and a consultant. Now you are peacefully seated here, and probably your kids must be at home under the care of your parents. Because of that, you're peacefully seated here and listening and working in the hospital. And think about your teachers from the beginning, your preschool to your higher studies. Teachers, because of them you are here as doctors, medical students, and because of teachers, your kids must be safely at schools, preschools, nurseries. So you rely on them for their safety as well. So we are now thinking about them and feeling grateful. Because of them, we are here. And when you feel grateful, what will happen to your mind? So it is a higher center human skill where your brain is rewired, and now we are thinking about neuro well-being. So you might think that being grateful only helps others, but not like that. It is so being grateful, that will help your brain, your neuro well-being. So that 1 second or 2 seconds will help you. So now when you feel grateful, then you go and show care. So this is elderly nutrition, not only your patients but your loved ones, how we are going to care and show grateful to them. So this is elderly nutrition. I am the consultant nutrition physician from National Hospital, and I am thankful for Kandy Medical Society for inviting me, and also the nutrition team, I think Dr.Evone and the nutrition team for inviting us, and also the SLCNP and SLAMNA for collaborating with them. And so within 15 minutes, I would like to go through elderly nutrition, how you are going to care for your parents and your loved ones, as well as the elderly patients. And who are elderly? You know, the definition is more than 65, but in Sri Lanka we define it as WHO as well, more than 60 years elderly. But it is a long journey towards there, so that some might live 100 or more than 100 years, and the problems will be very vast during their elderly life. So what will happen in next few years? Sri Lanka will become the South Asia's fastest growing population. So you will get more and more elderly people, patients for medical care as well as nutrition care. So we have to be well prepared ahead. And now globally they design the cities thinking about elderly population, because the world is growing old. So when you go, you will see a park for playgrounds for children. Now that will be in future, there will be service centers, park designed for elderly and also to improve their mobility and their service. So this is, so we are going to look at determinants of malnutrition. So in this picture, you will see lot of things which will leads to poor nutrition care. So I will begin with what are the three things, major things, that is low intake, high nutrient requirement, and low bioavailability, like absorption, reduced absorption. So all the other factors will lead to one of the major determinants of malnutrition, so that you will see most of the things beginning with D will lead to malnutrition in elderly, like dysphagia, depression, drugs like poly medications, and dentition, poor dentition, likewise. So there will be so many underlying factors. You have to look at the underlying factors and correct them to when you are going to correct their malnutrition. So these are the nutrition issues in elderly, and I'm not going to read about everything, but most of them are covered with previous lectures, like obesity and overweight, undernutrition, micronutrient deficiencies, and sarcopenia. I will speak about sarcopenia in elderly, because you know the sarcopenia, the lean body mass, is directly proportional to your longevity. So more muscles you have, you will live longer, and also your quality of life will be okay in elderly life. So these are the micronutrient deficiencies. I think the previous lectures has covered those things. I am not going to go to case scenarios, because you now know how to identify malnutrition, do the nutrition screening in elderly. These are the nutritional screening tools. Dr. Jayaweera has kindly discussed about it and the previous lecture as well. So this is the nutrition assessment, and when you diagnose malnutrition, you have to refer the patient to proper nutrition care. So in the first lecture, Dr. Lasithwenage correctly said, so if you see a obese or overweight elderly, you will refer them for weight loss. But we are not doing a fast weight reduction, because muscle loss. The muscle is really important in elderly life, and if you lose muscle, gaining muscle is very difficult in elderly. So I will explain why. So is there any guidelines? So this is ESPEN geriatric guideline in 2022. You can access the guideline freely, website, as well as there is ESPEN guideline app is available in your Play Store. You can freely download it into your mobile phone, and anybody is interested to sit for any nutrition screening exams, they can go through the guideline. Okay, so energy and protein. So according to the guideline, the energy requirement is 30 kilocalories per kg for elderly. If your mother is 50 kilos weighing 50 kilos, the protein requirement is 1 gram per kg, that is 50 grams. So energy is 30 kilocalories, that means 1500 calories. Okay, and liquids, they have to have, if the female, they have to have 1.6 liters per day. That can be, what are the options, I will let you know. So if a male elderly, daily fluid requirement will be minimum of 2 liters per day. Okay, so this is protein recommendations for dietary protein intake. Why we are stressing about dietary protein? Because their protein requirement is more than the adult requirement. you needs 0.8 to 1 gram per kg of protein, whereas elderly, your mother, your father, your grandparents, they need 1 to 1.2 gram. So at least 1 gram per kg to maintain their muscle mass. Okay, so this is healthy people. Why? The per meal anabolic threshold. So elderly, they have to have per meal protein 25 to 30 gram protein per meal to have anabolism, muscle anabolism. So less than that, it is very difficult to gain muscles. And also, this is like there's lysine requirement is there. That is what you call very much important in gaining muscles. So when they are ill, when they are ill, they are acute or chronic disease, their protein requirement is higher, but you have to guide with their clinical stage and their renal status. So 1.2 to 1.5, and in severe illness like a burn injury, their requirement can go up to 2 grams per kg per body weight per day. Okay, so you have to think about their renal status when you provide proteins. So the other nutrient requirements, we have RDA, recommended dietary allowance. You can refer to them. This is to tell you that adult requirement and elderly requirements, micronutrient requirements are different. So major difference is the calcium requirement is high, that is 1250 milligram per kg, and also vitamin D requirement is higher, so double than the adult vitamin D requirements. And it is very important to prevent falls, and vitamin D is linked to lower vitamin D levels linked to falls. Okay, so moving on to age related sarcopenia. So you know, when you assess sarcopenia, it is important to measure not only the muscle mass, the muscle strength and physical performance. So practically, if you have a hand grip, a dynamometer, or you know there is hand grip measuring equipment, so simply you can measure the hand grip. So hand grip is another way, simple way to guide your nutrition care as well. If the hand grip is improving, that will show that your nutrition care, the muscle power will be improving. So what are the cutoffs? So hand grip, this is according to the European working group, less than 27 kilos for men and less than 16 for females. If the grip strength is less than that, that is like malnutrition. So you can monitor your nutrition care through hand grip strength. So more about age-related sarcopenia, where you have to combine with exercise, strong component with resistance exercise, as well as there should be what else in elderly? Balance training with the nutrition care to prevent age-related sarcopenia. So now if you diagnose malnutrition, sarcopenia, then how are you going to feel elders? So you have to provide with small frequent meals, probably 3 main meals and snacks, 2 to 3 snacks. And what are the options? So elderly, you have to consider their cultural beliefs and their likes and dislikes and the ability to chew foods. So if they can't chew, then you have to make the diet accordingly modified to their ability to intake. So seasonal fruits and vegetables and variety of foods need to be included. What are the snack options? So the snacks should provide lot of micronutrients with because the nutrient requirement is higher, micronutrients, and targeting that you have to give snack options. Okay, and not only providing meals, you have to think about their emotional, social well-being, and to improve their appetite and diet, you can encourage them on home gardening, which will improve their physical activity as well. So you can see here, even though the person is chair bound, he can access. So there are so many methods that we can incorporate their service into home gardening. So engagement in the cooking with peer activities, so that their appetite will be improved as well as their social well-being will be improved. So to prevent sarcopenia, we have already mentioned. So how to provide protein? So these are the food items that can give this side is animal sources and the plant sources. So now the world is going towards providing both animal and plant protein. So you can remember we have said that per meal protein requirement should be at least 25. How to provide 25 gram protein? So if you can take fish 1 piece and 1 egg, that is 7 gram and 7 gram, 14 gram protein. So from other side, if you have lentils, half a cup, that is 3 tablespoons, that will be 7 gram protein. So total up to 21 gram of protein. So rice 1 cup will provide 4 grams of protein. So total up to 25 grams of protein. So you can say, so each and every meal should have 25, at least 25 grams of protein to have anabolic protein. So this will ensure the zinc requirement as well. So these are the options to provide adequate zinc levels, and we have already mentioned calcium requirement is high. So low fat calcium dairy options are there, and also 1 glass of milk. So this is 250 gram of calcium options here. And vitamin D, you know, the sunshine is there. So if you improve physical activity, that will improve their vitamin D levels as well. So liquids. So think about liquids. You can provide them king coconut water, and Ranavara, whatever the liquids, 6 to 8 glasses per day. And other issues, you have to think about the swallowing ability, the chewing ability, and the dental doctors can help providing good dental care. And if they have no dentition, then the artificial one will improve their nutrition care. And more about dysphagia modified diet, it is very important that when your parents go old, their diet should be a soft diet or easy chewable diet. So if they cannot swallow, then you have to go for modification like Dr. Thaksala said correctly. High calorie soups, not just vegetable soup. You have to add all the protein sources and proteins and also vegetables, food items all together, and include healthy fat into that and blend and provide it like this. So texture modified diet is very important in elderly care, and the most important thing is tender loving care. So when you care for others, the way you want others to care for you when you are elderly. So that is our lecture. Thank you very much for listening.
During next 15 minutes, I will be exploring with you about evidence-based practices in managing patients with regard to IBD as nutrition physicians. Most of us will enjoy a varied lunch today. Imagine someone telling a patient with Crohn's disease, do not eat any bakery items, no, skip processed foods, avoid them completely, or something like do not consume potato chips and the things like that, no red meat. How would it be? Well, that is the challenge of Crohn's disease exclusion diet, and also that is the power of it. Let me take you through that after laying the foundation about IBD a little bit. Well, as you all know, even as medical students, IBD is a chronic relapsing disease. Okay, and it is the main pathogenesis of that is chronic inflammation in the gastrointestinal tract. Primarily, we talk about Crohn's disease as well as ulcerative colitis when we talk about IBD. As you can see, Crohn's disease is a disease which can affect from mouth to anus, and it can involve any part of our GIT. Comparatively, ulcerative colitis is a disease where, okay, I think now the mic is on for Zoom people. Comparatively, ulcerative colitis is a disease which basically involves colon and the rectum. With that knowledge, let's move into the next slide. Why is it stuck? All right. However, in clinical practice, we do not appreciate IBD only based on anatomy, but also based on the depth of inflammation as well as the complications. Because when we practice as clinicians, it is very important to us, especially as nutrition team, because the intensity of our nutritional treatment would differ based on that. For example, we would treat more intensively to patients with Crohn's disease because they present with a lot of complications of malabsorption and lead into malnutrition as well. Looking at this in essence, you can see that Crohn's disease is basically a disease which can affect any part of the GIT, and it has skip lesions, and it is transmural, giving rise to complications such as malabsorption, strictures, and fistula. Whereas, in contrast, ulcerative colitis is a disease which affects, as I said, mainly to colon and rectum, and it gives continuous superficial lesions which affects mainly the initial part, which is the mucosal layer. It does not go transmurally, so it does not give strictures and fistula as such, but it can give to toxic megacolon, where the pathogenesis is it is affecting little bit deeper, and it is causing muscle paralysis, where the muscular layer becomes paralyzed and dilated and leading to gut paralysis. And also, in compared to Crohn's disease, ulcerative colitis carries a cancer risk. Especially, you have to know if a patient comes with pancolitis, or if a patient is having disease duration more than 10 years, or if the patient comes with more frequent relapses, then the cancer risk is higher. Well, let's look at the pathogenesis of IBD. It is quite interesting as well as quite little complex. It is little complex because it has 4 factors interplaying with each other. Not very simple like in certain diseases. Genetic predisposition. It is polygenic in origin. So not just
simple way of 1G. It says, research-wise, if someone is having IBD, a first degree relative with IBD, that person is having 10 times higher risk of developing IBD in life. However, even though genetics causing us susceptible, even though it sets the stage, merely that is not enough to cause the disease. It needs environmental triggers to start the disease. So it is very important for us to know what are these environmental triggers, because that is where we can act, isn't it? So the identified or research-wise proven environmental triggers which trigger this disease or initiate this disease includes mainly diet, especially processed foods, and high intake of refined sugars, high intake of fat, as well as low intake of fiber, fruits and vegetables. Keep that in mind, which will be helpful for you as well as for your patients. Not only that, as I said, it is little complex. Thirdly, gut microbe is also playing a role. So you may think it's only this gut microbial dysgenesis. We are talking a lot about that these days, where your gut microbiome is changing, their pathogenesis and their functionality, their composition is changing, more pathogenic microbiome is increasing, which we term as dysgenesis. Yes, it is a key factor. Gut microbial dysgenesis is a key factor for pathogenesis of IBD. But quite interestingly, even your normal gut microbiome can induce this disease. They mainly affect the integrity of the intestinal tract. Fourth factor is our immune system, our own immune system. As you all know, the immune system is protecting us all, but the thing is, anything coming exaggerated way or inappropriate way would be harmful. Same applies here. Your immune system, for the normal things even, for the normal gut microbiome even, your immune system is acting inappropriately as well as excessively. So the pathogenesis comes with all four factors acting together, causing IBD. Okay, let's go to diagnosis. Again, as the disease is complex, the diagnosis itself is not simply based on clinical symptoms. I will go through quickly. What you have to know, if a patient comes to you with IBD, with abdominal pain, diarrhea, rectal bleeding, or sometimes they have weight loss as well, the diagnosis of IBD is based on combination of tests. You may do fecal calprotectin, you may order lower GI endoscopy where they need full endoscopy, full colonoscopy. Together with that, you have to combine imaging. Especially the guidelines are telling us you have to combine a full colonoscopy together with an imaging procedure. So we talked about these things. Now we will go into the nutritional part. The current recommendation is, if you ask me the question, when do you have to screen the patient for nutrition? The answer is, as soon as you diagnose the patient with IBD, yes, that's the point, that's the time that you have to screen the patient for malnutrition using the different malnutrition tools that Dr. Jani elaborated. Then, is it that common? Why do we have to, you have to ask questions by yourself. Why do we have to screen patients at the diagnosis? That is because it is very highly prevalent among these patient cohort. Among IBD patients, malnutrition can go up to 65%, even with newer research, it says up to 80% it can be present. And also, more importantly, malnutrition can affect their outcomes and quality of life. If we look at the impacts it can cause, you can see if the patient is malnourished, they are prone to stay longer time in the hospital, which directly combines to the cost of the health care. And also surgical outcomes, because these Crohn's patients, especially, they undergo surgery sometimes, gut resections. So surgical outcome is utmost important in that case. So surgical outcome would be poor if the patient is malnourished when you compare with the normal patient. And also infection risk. If malnourished patient, they are prone to get infections more frequently, which goes as a vicious cycle, and they become more malnourished with the infections. And also therapy response would be poor in malnourished patients. So it is very clear that we have to act promptly to elevate the nutrition in these patients. Let's look at the pathophysiology and why it affects the nutrition of these patients. It is simple, because anyone with the condition which affects our primarily GI tract would come up with anorexia, low intake, obviously. And also plus that, these patients are having strictures, fistulae, which also complicates the picture. And also malabsorption, because the inflammation is primarily in gut. So it will lead to malabsorption. And also, as other doctors elaborated, whenever there is inflammation, there will be more expenditure. So we need more energy. Together with that, if we can't provide that, we can easily go into malnutrition. And also, as I said, Crohn's disease patients can go into ileal resections as complications are there. So they are having tendency to go to malnutrition. Together, all these factors play together and can lead the patient towards nutritional deficiencies. Well, the most common deficiencies in these patients include iron, B12, folate, which can lead the patient to anemia, and also vitamin D, calcium, which can lead to the patient to osteoporosis, and also other things. A lot of things are associated with vitamin D deficiency. And zinc and magnesium, especially important for children because they are important for growth as well. And also protein energy malnutrition, which is playing a part with sarcopenia, as you learned just with Dr. Shalika. So if we think about disease prevention, which is more important, the current guidelines are recommending protective foods for if you are intending to prevent this disease, which includes fruits, vegetables, and omega-3. And it is a well-proven factor with solid evidences that breastfeeding in children more than 6 months lowers the risk of IBD in future life, which should be one of your take-home messages. And also, the other side of the story. Certain food items and certain lifestyle behaviors can lead someone towards IBD, which includes high intake of fats, such as polyunsaturated fats and ultra-processed foods. Especially be careful with your children when you feed. And also smoking, stress, and antibiotic exposure. All right. This is an interesting question. If someone asks me, as we are nutrition people, is there a particular IBD diet that you can recommend an adult patient to induce remission? You know, this disease is having an active disease part as well as remission part. Active disease part is more dangerous, so we are trying to take them into remission. So is there any diet where you can avoid medication and prescribe this diet for these patients? My answer would be no at the moment, based on current evidences. There are no solid evidences for any global guideline making committees to suggest a diet for adults. But for children, there is a well-proven diet called, well-proven plan called exclusive enteral nutrition, which is actually the first line management for pediatric patients with Crohn's disease when they are presenting, especially with luminal Crohn's disease, with mild, moderate Crohn's disease, not severe Crohn's disease, because compared with corticosteroids versus the exclusive enteral nutrition, for pediatric patients, this has a lot of benefits, including with regard to their growth, as well as when we consider the side effects of the corticosteroids in children. Now, the world is talking more towards another alternative diets, which includes Crohn's disease exclusion diet, as I said you before. Well, this is a hot topic these days. Crohn's disease exclusion diet. What is it? Because even though I said you, this exclusive enteral nutrition is the first line and it is great, it is a complete liquid diet which is given for 12 weeks. Think of a child who is taking only a liquid diet. Even though we say child, maybe an 11-year-old child taking a liquid diet for 12 weeks. That means 3 months. It is quite difficult, isn't it? So then, some of the researchers in Israel, they have developed this Crohn's disease exclusion diet where you are incorporating whole food into your diet plan. This is a well-structured eating plan which goes as phase 1, phase 2 and phase 3. In phase 1, which goes for 6 weeks, you give 50% from enteral nutrition, as I said, in exclusive enteral nutrition, but 50% you give with whole food. And next 6 weeks, you go for 75% whole foods. And after 12 weeks, you go for completely 100% whole foods. There are some exclusion foods in this diet regime, which includes, as I said when I start the slideshow, ultra-processed foods, bakery items, red meat, gluten-containing foods. Likewise, there are some exclusion foods. But compared to the other strict regimes, this is much acceptable. And the good news is, at 6 weeks, 80% of the patients who follow this dietary regime show remission. But the only problem at the moment, this is not developed for the adults. This is only recommended for children at the moment. But there are ongoing research whether this is suitable for adults or not. So we will hopefully wait for that. Okay. Another hot topic these days, the role of probiotics and prebiotics. However, the role of probiotics or prebiotics in Crohn's disease is not proven by scientific research with enough evidence. Evidences are there, but they are not solid enough to come for a recommendation level. However, probiotics such as multi-strength probiotics can be used in mild moderate ulcerative colitis. Well, like in any other disease such as pulmonary, liver or any other disease, here also multidisciplinary care is utmost important and patients should be managed by a team of experts. Well, for the sake of completion, I have entered enteral and parenteral part as well, but it is in-depth knowledge. For your level, I will just mention, if your gut is functioning, use it. If your gut is not functioning, if your gut is insufficient, if your gut is having complications which are absolute complications, such as anastomotic leaks or high output fistulas, then go for parenteral nutrition. That's all. Thank you.